All right, so this is our second lecture for Chapter 2, and in this lecture we're going to be talking about the spinal ligaments and the intervertebral discs. There's a lot of ligaments. We're going to kind of keep this simple for you because you just kind of know what two structures these attach to and what their major function is. So we'll start with the major one here, and there's a good chance you'll see this in your cadaver, is the anterior longitudinal ligament, or ALL. It's a thick sheet-like ligament that runs down the anterior surface of the vertebral body. So this is a great picture of it right here. Okay, so see how it's this long, thick structure here. Now what does it do? If you look at a sagittal view here, it prevents anterior displacement of the intervertebral discs. So you have these discs here in between each vertebral body, and it prevents them from translating anteriorly. And then it also helps prevent, so if you have your spine here like this, okay, so this is your spine, it helps prevent hyperextension. So it helps prevent this way, okay? Extension of the spine is where you extend back, like if you were to lean back. Flexion of the spine is considered where you flex forward. Simple, but you don't. It's something you hear in everyday life, and you want to make sure you have that straight, okay? Because when you're talking in these terms, you want to understand what's going on. Okay. Posterior longitudinal ligament. Okay, so here's it's also called the PLL. Here's your ALL, okay, running down the anterior surface. The PLL runs down the posterior surface. Now it runs within that spinal canal, so inside the vertebral foramen that we were talking about, and it extends from the C2 vertebrae along the posterior surfaces of the vertebral bodies. So this is a posterior view, and we have the pedicles here. This is your pedicle, okay, and then the lamina and spinous processes and all that are cut away, okay. And so you have this PLL running down the posterior surface like this, as you can see. This is a great picture of it. And just on the posterior surfaces of these discs as well, okay? Now, what does it do? It prevents posterior displacement of the intervertebral discs. So you have these discs here, prevents them from going posteriorly like that, okay? It also prevents hyperflexion, okay? So bending forward. And the reason these ligaments you want to prevent either hyperextension in the case of the ALL or hyperflexion in the case of the PLL is you don't want to have too much flexion, too much extension, because that creates instability, which can make you susceptible to injury. Okay, so these ligaments are very important. So next, the ligamentum flavum. This attaches adjacent vertebral lamina, and we got a couple pictures here because this is something that can be difficult to understand when you're first learning it. It's a ligament that has a high elastic tissue content, so it provides a lot of elastic recoil, which can be useful when the vertebral column is, assuming its normal position after flexing, okay? And then it also protects the spinal cord posteriorly, and we'll talk about that in a second. So we want to give you a good view because this is a ligament that can be kind of hard to understand when you're first learning it. And so what we'll show you here, this is a sagittal view, is it connects both lamina to get the superior and inferior vertebrae, okay? So you have your pedicle, your lamina, ligamentum flavum, connecting both here, okay? This is another good picture. So you have the pedicles brought out here. This is just the beginning of the lamina where it would, at the junction of the pedicle, and you can see just the beginning of the ligamentum flavum here. If we look at a posterior view here, so let's draw here. So this is a posterior view, just to give you, and then we have our spinous process like this, okay, and this is our lamina, okay, and then we have the just superior vertebrae, okay, so we have like this, then we have our lamina like this, okay, the ligamentum flavum is going to be like this, okay, it's going to be connecting the lamina on both sides just like this, okay. And as you can see, inside of here is the vertebral canal, which is where the spinal cord is. So you can see why it protects the spinal cord posteriorly. Okay. Now, these are some quick ligaments. We got a bunch here on one page. We're just going to run through these real quick. So you got this. We'll start out here. Supraspinous ligament. So again, this is your posterior view, posterior, anterior. This is a sagittal view. So you have your supraspinous ligament, and it spans between the tips of adjacent spinous processes, beginning at the C7, T1 vertebral levels, that junction between the cervical and thoracic spine. So as you can see here, it's jumping from spinous process to spinous process, okay? And so it runs on there. Then you have the interspinous ligament, which attaches to adjacent spinous processes. So if we go in one further here, this is on the interior, or between each spinous processes. You have the interspinous ligament here. So then you have your intertransverse ligament, which attaches between adjacent transverse processes. So if we go in an anterior view like this, and this is going to be kind of a cartoon here, so you have your pedicles out like this, lamina like this, okay, transverse processes out like that, okay. Then we'll draw, our disc here. Then we'll do another vertebral body like this, and then your pedicles are out like this. Lamina's hidden behind there, the superior vertebrae there. So that's our pedicles. Transverse process comes out like this. We'll just for completeness sake, we'll draw it like this. And again, it's a cartoon. They're closer together than this, but this is just to give you an idea. So this would be your intertransverse ligament. So it connects both transverse, and this is an anterior view. Okay. Now, one thing I want to point out here is that the ALL is much stronger than the PLL. Now, why is that? Well, if you look at anteriorly and posteriorly here, there's a lot of ligaments providing support to the spine and preventing hyperflexion posteriorly, okay? Versus there's only the anterior longitudinal ligament anteriorly, okay, preventing hyperextension. So if we do a little algebra equation here, you have ALL is equal to the PLL, but not directly. Also plus ligamentum flavum plus the interspinous ligaments plus the supraspinous ligaments plus the intertransverse ligaments. Okay, so the ALL has got to have the same strength as all of these put together. Okay, you could think of it as an equilibrium. So that is why the ALL is much stronger, because the posteriorly you have a lot of ligaments acting to help prevent hyperextension. Now, there's some unique cervical ligaments. So there's the cruciform ligament, which is really two ligaments in one. The transverse ligament, which we've talked a lot about, is in the C1 here. So this is your C1 vertebra, excuse me. Okay, and you have this transverse ligament. This is a great picture of it. So it connects both lateral masses, and then it arches over this odontide process coming up from C2. Okay, then you have the longitudinal ligament, which helps connects. If you look at the posterior view here of the cervical spine, it helps connect the apex of the dens to the anterior region of the foramen magnum. So you have the foramen magnum here, you have the dens here, and it helps connects those two structures. Okay. And then it also helps connect a little bit to the body of the axis as well. Okay, and that's just to provide some stability in the region. The much higher yield one is the transverse ligament. Okay, this is because that's relevant if you remember in our Jefferson fractures. Okay, and if you remember, if this is torn, that creates an unstable Jefferson fracture. Then you have the tectorial membrane, which extends superiorly from the PLL. So if we go at a sagittal view here, okay, so you have PLL that extends up here like this, okay, on the posterior aspect. So we'll have this be anterior, posterior. This is PLL, okay. PLL is going to stop here at C2, okay. Then you got C1, then you got the skull here, okay. So what the tectorial membrane is going to do is it's going to extend from the body of C2 all the way up here to the base of the occipital bone, okay? So this is going to be this region here will be tectorial membrane, okay? It's really just, you could think of it as an extension of the PLL up here in this C1, C2 region that extends up through the foramen magnum, which is just the foramen in the bottom of the skull that allows the spinal cord to exit the skull. Then you have the nuchal ligament, which you could think of this as similar to the supraspinous ligament in the upper cervical region. So it extends from the external occipital protuberance, which is just a fancy word for a bony prominence on the posterior aspect of the skull, and it goes across the tips of the cervical spinous process, and then it's continuous with the supraspinous ligament at C7, okay? So if we draw, let's actually go to the whiteboard for this. I just want to help you fully understand this. Okay, so this is a lateral view. This is C1. You have the skull like this. C2, and then so on. We'll go down here to C7. Okay, we'll skip down here. And then you have your spinous processes like this. Okay, so what the nuchal ligament is, extends out from that posterior occipital protuberance, and it goes down the tips of the cervical vertebrae, and then it goes all the way down here to the C7, which then is continuous with the supraspinous ligament. So it's a specialized ligament for a special supraspinous ligament for the cervical region. So that's the nuchal ligament. Okay. All right, so now we're going to get into the basic structure of intervertebral discs. We're going to talk a lot about discs throughout this whole lecture series on the spine, because really this is both clinically, this is a very high yield thing, and then also especially for your board exams, it's almost a guarantee on your step one you're going to get some kind of disc herniation question. It's usually going to be someone presents with a disc herniation and they're going to ask you to localize which nerve root is impinged. And don't worry, in the clinical pearls section at the end of the chapter, we're going to go through how you can localize each nerve root using the physical exam findings and presentation. We got you covered, don't worry. So here we're just going to give you the basic structure. And then again, later in the lecture, we'll talk about neural structures that are affected with disc herniations, and then last in the clinical pearls, we'll talk about unique presentations and physical exam. So what is an intervertebral disc? We've been talking about it a lot lately. It's a fibrocartilaginous ovoid shape. So if you remember from the basics of musculoskeletal system lecture in chapter 1, we talked about fibrocartilage, okay? So this is an example of fibrocartilage. Now, the whole disc isn't fibrocartilage, just the part of it, and we'll explain that in a second here. It lies between the adjacent vertebral bodies and forms the symphysis joint. Now, what is its function? It allows movement between adjacent vertebral bodies, and the big thing is it acts as a shock absorber, okay? Now, here's a great picture of it. So this is a lateral view here, and then here's an axial view or superior view of a disc, how it looks between vertebrae, okay? Now, what are the components? So if we look here, you have your nucleus pulposus. This is a gel-like core. So this is the core here, and it's composed of all these different things, all your favorite things from biochem right here, all in one. Proteoglycans, glycosaminoglycans, collagenous fibers, all immersed in this mucoid material. So it's really like this jelly, thick, viscous, jelly-like content that's found in the core here. You could almost, some people will think of it as like a jelly donut, an intervertebral disc, and this is like the jelly inside. Then you have the outside of the disc, which is the annulus fibrosus, which you can show here. This is what's shown here and here. And the annulus fibrosus is the part that's fibrocartilage, okay? So the nucleus pulposus is not fibrocartilage. It's not considered cartilage, okay? What's considered cartilage and fibrocartilage, to be specific, is the annulus fibrosus, which is made up of rings of collagen type 1 and type 2, so it's going to be extra strong, okay? So this annulus fibrosus is a nice thick structure, encloses this mucoid core here, okay? Now, a disc herniation, what is it? It results from a breakdown of the annulus fibrosus, okay? And that makes sense. It's the tough structure. That's what's going to break down. And so usually what happens is this will break down, and then what happens is the nucleus pulposus will protrude posteriorly through this opening in the annulus fibrosus, okay? And it'll herniate out, and it can potentially compress the contents here of the vertebral canal, which would be spinal nerves exiting out from the spinal cord. It can compress the spinal cord, but the PLL is pretty strong. And so what happens is the PLL really causes it to herniate more posterior laterally than directly posteriorly onto the cord. So that's why it affects nerve roots much, much more commonly than the spinal cord itself, okay? So it'll herniate posterior lateral here and affect the nerve roots as they exit out of the vertebral canal, okay? So it most commonly occurs in the cervical and lumbar regions. It's very rare in the thoracic region to have a disc herniation. And why is that? It's because the vertebrae in the thoracic region, they're fixated by the ribs, which are then fixated to the sternum, which is your breastbone in the front. And it's all forms this structure called the thoracic cage or rib cage. And as a result of that, these vertebrae, they undergo much less movement than your the cervical and lumbar regions. If you think about it, your cervical, you move your neck all the time. And so that's your cervical spine undergoes a lot of stress over the years. Your lumbar spine is involved in, you're bending and you're flexing, and it bears the majority. Even though your weight is more evenly distributed because of that S shape, the lumbar spine still bears the majority of the weight, okay? And so it has a lot of stress on it, and that's the other reason that disc herniations are very common in the lumbar region. All right, and that closes out our discussion of the spinal ligaments and the intervertebral discs.